Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, it is RSV season. Dr. Georgina Peacock is the director of the Immunization Services Division in the National Center on Immunization and Respiratory Diseases at the U.S. Center for Disease Control and Prevention. She talks everything RSV with Dr. Josh Sharfstein, including who is most at risk, what can be done to prevent infection, and whether people will have access to key vaccines and antibody treatments this year. Let's listen.
Dr. Georgina Peacock, thank you so much for joining me today on Public Health on Call to talk about RSV. And let's start perhaps with a basic question. Can you remind us all what RSV is?
Sure. So RSV, and the long name of it is respiratory syncytial virus, is a really common respiratory virus. Usually looks like the common cold. It affects the nose, throat, and lungs, but it can make infants and older adults really sick.
When infants and older adults get really sick with RSV, what does that look like?
Typically, it means they have trouble breathing, and so they need help in the hospital, either with oxygen or other things that will help them get through the illness.
And does RSV lead to some deaths every year?
It does. So it can lead to deaths both in infants and in older adults.
Now, if I remember correctly, RSV is seasonal. So there's some parts of the year when we see many more babies and older adults getting sick with RSV. What is that season?
Yeah, so for most of the United States, that season starts in early October and then it goes through March.
Got it. We're recording this podcast in early October.
Yes, we are. So we are starting to see a little bit of that increase in RSV in the southeast of the United States, which is what we would expect. So we're starting to see more RSV in the community.
Now, you're at the Centers for Disease Control and Prevention. How are you all monitoring the RSV season this year?
So every year we monitor RSV and other respiratory viruses by looking at hospitalizations, by looking at who shows up in the clinic with something called acute respiratory illness. So those symptoms, like we were talking about, that affect your nose, your throat, your lungs.
Do you have a sense yet of whether this will be a particularly bad season for respiratory viruses in general or RSV in particular, or is it a little too early to predict?
I think it's a little early to predict. I did just see the report yesterday, and they put reports on the website the CDC website every week. And, the map is green. So it means we're not seeing lots of respiratory illness right now. So we're expecting a typical season, but it might be a little too soon to tell.
Understood. Well, let's talk about ways that we can protect ourselves from severe RSV, and in particular, ways that the vulnerable babies and older adults can protect themselves. Let's just maybe quickly start with the older adults. What options do they have?
For older adults, there is a vaccination. So there's a vaccination that was first available last season, and it's recommended for people over 75, and then people with chronic illnesses should talk to their doctor if they're over 65, because that may be eligible as well.
So for people listening who are over 65, they may want to talk to their doctors. Over 75, really think about getting this vaccination to protect against a severe respiratory illness like a pneumonia from RSV.
Right, because we know the older that you get, the higher risk you are of having complications and maybe needing to be hospitalized from RSV.
So if we have a 95-year-old listener, they should especially be paying attention to this.
Yes, absolutely.
Okay. Let's switch to the other end of the age spectrum. Which infants are most vulnerable to RSV?
The infants that are most vulnerable are children that are born prematurely, children that may have certain kind of chronic illnesses, maybe like, cystic fibrosis or something like that. But really, all infants are at risk for, when they're really little, at risk for getting sick from RSV and getting hospitalized.
Now, there were a couple of new products that came on the market last year, one of which I think was given to the parent prior to delivery. Is that right?
Yeah, so there are two products. That product is the RSV vaccine. It's actually the same vaccine that you give to older adults, but a pregnant woman can get a vaccine between 32 and 36 weeks of gestation.
And for which people is that vaccine recommended now?
So that's recommended for any pregnant person between that time during pregnancy, so 32 to 36 weeks. And the reason for the vaccination is to protect the infant.
Got it. So the parent gets the vaccine, the baby is protected against severe illness.
Right. So the protection lasts about 6 months. So for that first 6 months of the baby's life.
Now, what is the other product that's available?
So the other product is what we call a monoclonal antibody. And the name of it is nirsevimab, which is a long name. The brand name is Beyfortus.
And by monoclonal antibody, we're talking about a medication that is basically one precise antibody in a high quantity that really targets this virus.
Right. So it's another way to protect the infants against complications from RSV.
And who should get this antibody?
So all infants that are born October through March are recommended that they get that antibody, the nirsevimab, within 1 week after birth, and typically in the birth hospitalization. And then any infant that isn't born during the respiratory season, that October to March, should get it before 8 months of age.
Got it. Now, that speaks to the vulnerability of potentially any baby when they're small enough.
Right. So this is definitely something where we see the younger the babies are, the younger the infants are, the more likely they are to have hospitalizations.
Now, if we have a baby whose mom got the vaccine during pregnancy, does that change the recommendation?
So if they got the vaccine during pregnancy, then the baby does not need to get the nirsevimab.
Got it. So we're talking about babies born during those months, no maternal vaccination happened. We talked about this last year, just when this product came out, and there was a lot of anxiety about getting it because there were certainly babies that were vulnerable, particular premature babies, and we talked to some clinicians who were pretty stressed about finding it. What happened last year?
So last year, there was a lot of demand for this new product, and I totally get it. I mean, when I was in residency, I admitted 20 infants one night, with RSV, and there was less supply than was expected. And so there was a problem with having enough supply for all of the, infants that needed it.
How are we doing this year?
This year, we've just started, but we've been able to order enough immunization, enough of this product through the Vaccines for Children program, which is the program that I oversee. And also on the private sector, we understand that there's enough out there. And so that should be flowing into offices and birthing hospitals right now. And so we're not anticipating that there is any shortage problem.
That would really be great. And it's super that the Vaccines for Children program, which makes vaccines available, particularly to low-income children around the country, is carrying this immunization, this antibody. For those kids, the government carries the cost of those products. For privately insured kids, sometimes it has been challenging for pediatricians to order if they have to put the money up front. Is that continuing to be an issue, you think, for this product?
Yeah, that is the case for all vaccines, on that the private pediatricians or the birthing hospitals need to put that money up front when they're buying the vaccine. What I do understand is that the reimbursement is happening. So, by law, by the Affordable Care Act, routine childhood immunizations are covered. And so the vaccines, and this product is no exception, should be reimbursed by private health insurance.
Got it. So hopefully every child can have access, whether through the Vaccine for Children's program, even for uninsured children, or through private insurance. That's really the goal for child health this year.
That's right. And one population that I forgot to mention when you asked me before that also is entitled to this product through the Vaccines for Children program is American Indian Alaska Native children, and they are also a population that are high risk for complications from RSV.
That's really important to mention. Thank you. So we have a long-standing, very severe illness for some kids that now has a highly effective preventive intervention to keep kids out of the hospital. I certainly remember kids really struggling to breathe with this condition from my own pediatric residency. It's a pretty big step forward.
Yeah, it's pretty amazing. I mean, I was so excited when this product came on the market last year, and it was challenging to have those shortage issues. And so I really am looking forward to a season where we get even more children immunized this year.
Dr. Peacock, I don't know if you have this number handy, but how many young children are hospitalized every year for RSV?
It's about 80,000.
And I know this may be asking you to speculate a little bit, but if we were to be able to get all of them, these new products, how much of a decline do you think we might see in that number of hospitalizations?
So it would be a pretty dramatic decline because our early real-world data shows that Nirsevimab was at least 80 to 90% effective in preventing babies being hospitalized with RSV if they had RSV. So a big dramatic decrease if everybody were to get that immunization.
Wow. I mean, that is a lot. I mean, that's kind of like 70,000 fewer kids getting severe illness with all of the stress associated with that for their families, not to mention the risk of long-term complications.
Yeah, I mean, I think totally game-changing for families and for the pediatricians and the hospitals. I mean, that would be huge.
Well, let's hope the game is changed this year. Thank you so much, Dr. Peacock, for joining me.
Absolutely. Thanks for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production management by Catherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Eliza Rosen. If you have questions or ideas for us, please send us an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.